Alright guys, welcome to this video on step 2 exam questions. We're just gonna get straight into it. We have a 64-year-old male. He was brought to the ED 20 minutes after sudden onset severe chest pain radiating to the back. Pain began while he was sitting. He has a history of poorly controlled hypertension, hyperlipidemia, he's diaphoretic, he's restless. And then temperature is afebrile, pulse is 92, respiration is 24, blood pressure is 186 in one arm, and then 142 in the left arm. Pulse oximetry on room air shows 99%. Cardiac examination reveals an early diastolic murmur. Lung examination shows decreased breath sounds at the left lung base, and EKG shows sinus rhythm with left ventricular hypertrophy and no ischemic changes. Chest X-ray demonstrates widening of the mediastinum and a small pleural effusion. Which of the following is the most appropriate next step? Okay, so what is the diagnosis? I mean, there's a couple of things going on here. He has a small pleural effusion, so we're thinking something respiratory. He has, severe chest pain. He has a history of hypertension, hyperlipidemia. He's diaphoretic. He's restless. This kind of paints the picture of an MI. At the same time, they mentioned this finding here, blood pressure differential within both arms. This is a very good sign of the aortic dissection. And then they have an early diastolic murmur. We're painting this picture of decreased breath sounds. There's multiple things going on. This is the big picture, guys. I want you to always think of a question, think of a big picture. Is this a severe presentation? Yes. Okay. I want you to think of the big picture. Multiple systems are being affected, respiratory, cardiovascular, and then, he has this new diastolic murmur. So let's go through the answer choices. One, we have thoracentesis. The thoracentesis would be for the small left pleural effusion. This is wrong because really the thoracentesis is likely a complication of something else, okay? This is not the main thing that's causing the person's symptoms. Thoracentesis, technically, if this patient was presenting with a pleural effusion, dyspnea, shortness of breath, then we can think of a thoracentesis to target the underlying issue, which would be the pleural effusion. Here, it seems like a side thing, okay? When you look at these questions, you have to paint a picture. The main stem, all of this is talking about this chest pain, blood pressure, hypertension, hyperlipidemia, and then they throw in the end, small pleural effusion, lung exam, decreased breath sounds. Okay, they're not focused on the respiratory system, so we're going to cross this out. Administration of TPA. Well, depending on the diagnosis, we can't give TPA, okay? TPA would be catastrophic in this situation. I'm just going to give you the answer. The answer is this is a aortic dissection, okay? Aortic dissection is going to lead to multiple problems, okay? You're thinking of a new early diastolic murmur, okay? Decreased breath sounds, multi-system problem with severe cardiovascular collapse. You should think aortic dissection. And administration of TPA is just going to make everything worse. Never give this in any, hemorrhage, any aortic problem. This is going to just kill the patient. TEE, this is actually going to be the correct answer. This is the first line for patients who are unstable with aortic dissection. Placement of a left chest tube, once again, no, we're not targeting, this pleural effusion is not the main problem. Emergency coronary angiography. This would be the answer if the patient was presenting with an MI, okay? But the thing is, you cannot have an MI if the EKG shows no ischemic changes. This finding right here, no ischemic changes, means you essentially rule out an MI with that TEE. A few things about aortic dissection. This finding right here, guys, pay very close attention. This finding, blood pressure is 186 in his right arm and 142 in his left arm. This shows up very few times, guys. There are very, very few times where this shows up, and when it does, you're thinking of aortic dissection. This is the most important physical exam finding when it comes to aortic dissection, and we'll talk about this later, okay? So just keep this in mind. Let's talk a little bit about aortic dissection. Hypertension is the most common cause of aortic dissection. Trauma, rapid deceleration is going to be the aortic isthmus, and then Marfan syndrome. These are the main three you should memorize. These three, you can keep at the back of your mind. Cocaine makes sense because what is cocaine going to do? It's going to spike your blood pressure, which can cause the aortic dissection. Bicuspid aortic valve, this is something it's in the risk factors, but just keep it in the back of your mind. I don't think they're ever going to test you on this specifically, but just, you can have it. Ehlers-Danlos syndrome, this can show up, but it is a lot more likely that one of these three will be the presenting factors, and they will always mention one of these three, guys. It will either be a trauma case, a patient with Marfan syndrome. They are going to start giving you weird descriptions. They're going to start talking about his height, about his width span. They're going to say he looks tall, he's slim. All of these features, if they ever mention a patient's, diameters, height, width, things like that, start thinking Marfan syndrome. Elastic joints, hyperelastic joints, think of Marfan syndrome. Pectus, think of Marfan syndrome, okay? Like I said, aortic dissection will always be one of these three cases. In this case, this was a 64-year-old man. In this case, poorly controlled hypertension. Okay, that was the case here. So hypertension, most common cause. And the way that works is intimal tear, blood enters the media, creates a false lumen. So essentially, there's a tear right here. Boom. And blood is coming this way. And then it starts going into this tear. And now it's a flap. Okay, now blood is going this way and then going that way. Medial degeneration, hypertension. So essentially high hypertension. Guys, think of this is the wall of the aorta. When you have blood pressure just coming slowly, it's just coming like this, it's not really going to cause any damage. But if it's coming like this, guys, if it's hitting the wall, eventually this wall is going to break, okay? If it's coming fast, rapidly, you can imagine the stress is going to break the wall. Eventually it's going to tear and create a false lumen. So symptoms, sudden onset. It's always going to be sudden onset, severe pain, or the patient will be unresponsive, okay? Always sudden or responsive, tearing, ripping, sharp, key feature. That goes to the back. This tearing goes to the back. Huge clue, guys, huge clue. Once they start mentioning, the pain radiates to his back and is tearing, stop thinking of an MI. This is not a myocardial infarction. This is going to be an aortic dissection. Okay, to the neck, abdomen, these are less likely. It is not pleuritic. It's not positional. It's not exertional, okay? If they start mentioning like the pain improves when I'm sitting up and leaning forward, or the pain improves, the pain is worse when I take a deep breath, none of that is pointing towards aortic dissection. Vital signs, hypertension or hypotension, guys. Okay, this can be either one, hypertension or hypotension. So just because hypertension is a risk factor doesn't mean they're going to present with hypertension. They will say he has a history of hypertension, but when he presents, he might be hypotensive, tachycardia or bradycardia, and then blood pressure difference between the arm. I want you guys to circle this and memorize this forever. This is the most important sign for an aortic dissection. If they mention this finding, this is a very easy question, okay? Like I said, physical exam, asymmetrical pulses, new diastolic murmur. This is mean that the dissection is going backwards, and going back into the heart will cause aortic dissection. JVD crackles, new heart failure. Neurological deficits will cause carotid involvement, abdominal pain, mesenteric ischemia, limb ischemia, chest x-ray findings, widened mediastinum. This is the most important one. These ones, you can know, but this is the most important one. I wouldn't even focus on these. Definitive diagnosis, you're going to do a CTA with chest if they're stable, TEE if they're unstable. MRI is not going to be the answer, guys. They might throw in MRI there. MRI is it's going to take a long time. It's not used acutely. And then as far as classifications, Stanford A, you guys already know this stuff. I'm not going to go through this. Initial management, this is important. Beta blocker first, and then you add the vasodilator, okay? Beta blocker first, and then you add the vasodilator, esmolol or labetalol, and then you add the nitroprusidone. Why? If you give them this will just spike their heart rate, okay? If it spikes their heart rate, they're just going to vasodilate. It's going to cause reflexive tachycardia. That tachycardia is going to make it worse. Okay, you want to slow the blood pressure, stop the blood from shearing and pushing into the vessels, and then you can vasodilate. And then as far as complications, remember, these can be the presenting signs. So someone comes in with an MI, and then he also has, for example, a pericardial effusion, and then they also mention renal. Think of aortic dissection. The big picture I want you guys to take away from this: aortic dissection is going to cause multi-organ system failures or multi-system, symptoms. Spinal arteries can cause paralysis, mesenteric, bowel ischemia, limb ischemia, stroke. Someone can present and they'll be like, oh, he can't move his arm anymore. All of these things, aortic dissection is going to give you the answer. And then these are some chest x-rays. Notice the mediastinum widening. Okay, this is very widened. Over here, once again, mediastinum widened. And it just looks off. And then just in case they ever give you a CT scan, you can see it right here. This is the ascending aorta. This is the descending aorta. You can see an intimal flap, okay? You can see these flaps. And let me show you that. So just take a look at this, okay? This is the flap. This is the flap. That's it. That's aortic dissection.